We have about 10 minutes for discussion. I think without wasting much time, I'll go to discussion straight away. So if you have a patient who comes with papillae and redness and watering, which is the drug that you would prefer to give? Can you tell Dr. Jairam? What is your personal preference?
Definitely, I just wanted to
Okay.
talk.
I'm talking about this seasonal allergic conjunctivitis. What would Vinay No, well, like very, like papillae would be something like moderate, and patient is complaining of itching and watering. So among the different antihistaminics that are available, which is your first choice? First question. Second question is, will you start steroids straight away?
Yeah, to answer the first question, I think still it is olopatadine is my first choice. Okay, and then about steroids, that will depend upon the extent of inflammation the patient is having. Okay, based on that, we take a call on steroids. If it is a mild, itching, white eye, probably no. But then inflamed, chemotic conjunctiva, I would definitely start topical steroids.
Okay, Dr. Aravind.
Yes, sir, steroids are mainstay because unless you start first, they'll go to another ophthalmologist, and the second ophthalmologist will become a hero. So, very practical point. Because definitely, sir, first we have to give steroids, then maintaining things. And one more point, I just wanted to, all through the discussion, we need to educate, because I believe that was missed out in all the discussions. We need to educate the parents that steroids are to be used under caution, under the supervision of the ophthalmologist, no repeat purchase, etc. Because many times they are reluctant to come, pay the consultation fees, and the doctor writes repeat all. That I can as well, buy from the medical shop. So nowadays, thankfully, the pharmacists are also aware of it. They have been educated to a certain extent. They keep telling, they give a call sometimes. Doctor, steroid, he is asking for more. Should I give? Outside pharmacist.
Okay.
So that's very nice of him.
So I think I should admire your pharmacist. We don't have such luxuries. Okay, fine. So the take-home message is, if it is a very mild one, you can get away with your olopatadine drops. So which one, among the antihistaminic drops which is available, which one would we prefer? That was my initial question actually, whether it is epinastin, olopatadine, or the new kids in the block, alcaftadine and all that.
If you really ask me to give you an evidence-based answer, I don't have an answer.
No, that nobody has. I mean, as a ocular surface specialist,
yeah,
and
I'm practically comfortable with olopatadine. I've had no complaints, so I've found no reason to shift to something else. Yeah.
So that is something that is seen. Olopatadine is
The advantages, as the companies claim, alcaftadine is once a day, but I still believe many times once a day doesn't work.
Yeah.
We need. I think you may agree with me. So once a day doesn't work. Whatever Pataday or any OD doses bottles, a day is never a day. You have to make it twice a day. Is what my.
Okay, so any of the dual action antihistaminics would do, but epinastin, olopatadine, or alcaftadine you can use. Alcaftadine, even though there are some company-sponsored studies which promote the use of alcaftadine, at least in my practice, I have not seen it to be superior to olopatadine. So I stick on to olopatadine. And I think if you can combine the NSAID, it makes more sense because it acts on that cyclooxygenase pathway also. So then if you have a more severe allergy, like now we're talking about seasonal allergic conjunctivitis. If you have perennial allergic conjunctivitis, as you see in our country, a lot of them, easily more than 30% of them, are having perennial allergic conjunctivitis, which quite often can go down to some other higher stages also. So what is your treatment choice?
So again, long-term therapy with the cyclosporin drops, tacrolimus, and lubricant, copious lubricant, because lubricant is the only thing which they can put it, say, 4 or 5 times a day. Among all the drugs we have listed here, copious lubrication, educate the parents, make a check on the surroundings, reduce exposure to fan, AC, travel, all dust and allergens, and again, all these things what we have told. And keep a check on what steroids we are giving. Sometimes one ophthalmologist has given lotipride, he comes back without no response, we shift him to dexamethasone. And as Dr. Sanjeev has showed that, it's such a scary epidefect. At least I will not dare to put prednisolone, but he has rightly put prednisolone and it has healed well. So step by step we go based on the intensity, and many teenage children, they need treatment for months, years together. So just one question as it just came. Teenage means I had tried BCL for a patient with allergy. Actually, he was quite better with all these papillae, 13-year-old boy. But again, the contact lens itself induced some irritation or what, I don't know. After 6 months, we had to discontinue. Any take on that?
Basically, sir, the BCL is just like a blanket over the fire. So it's just preventing the friction of the lid on the surface. So what happens is that as the toxins build up under the BCL, you will end up with BCL associated allergies as well. Because it's already a hyperreactive surface, it's already hyperimmune. So the reaction in fact occurs quicker. So if this patient was a normal CL wearer, would have got this allergy in maybe say 5 or 10 years of CL wear, he's got it in 6 months. Basically, that's all it is. So contact lens, no. So if you have macropapillae, it's best to start them on a full dose steroid. There's no use in giving mild steroids. You give them steroids, and for the maintenance, you give them antihistamines. So the steroids first have to suppress the immunity. But you also try your best to start them on the immunomodulators, which is your tacrolimus or cyclosporine A, because they take 4 to 6 weeks to build in the system. It takes a 4 to 6 week lead time for tacrolimus and cyclosporine to act. So by the time you're weaning them off the steroid, by then the immunosuppressant will take over. And as usual, the supportive therapy will continue.
Yeah, I think it's time for us to leave the stage, but still I would conclude saying that steroids initially has to be used. I think there is I don't remember his name now exactly, that Italian person who has worked a lot on VKC. I think he has more than 15 years he has worked. He uses only dexamethasone drops, but he doesn't taper it like that, he just uses for 4-5 days till your cyclosporine or some other drug takes effect. So to initial kill, I think he uses only pulse steroids. So that makes real sense. I think with these words, we have to conclude now before Marian and Co. Pardisin.